The dream machine. .com, HL7, I18 in the snap. We're building the future, never looking back.
Welcome to Imaging Informatics Unplugged, and today we are going to talk about what some are calling the 21st century stethoscope. Yes, that's right, we're jumping into the world of point-of-care ultrasound, or as those in the know like to say, POCUS. Now, these incredible devices have given new insights to clinical users right at point of care. It's changing the way that patients are treated, but let's be honest, if these are not implemented properly, POCUS can create more headaches than a stadium concert. And today there will be no hocus pocus. We're going to focus. And yes, that is a reference to a 70s prog rock song from a Dutch band, Hocus Pocus by Focus. I couldn't resist. Our guest today is someone who knows POCUS inside and out, Allan Bottemiller. Allan is an expert in medical imaging informatics, and he has been chairing a joint working group with the HIMSS enterprise imaging community in collaboration with the AIUM. And this group recently published a white paper that explores governance considerations for point-of-care ultrasound. So whether it's governance challenges or practical deployment, Allan has us covered. So buckle up, get ready to learn why POCUS is changing the game and how to avoid those implementation headaches. And if you're enjoying this content, I'd love it if you could like and subscribe. It helps. And with all that said, let's jump in. So welcome, Allan. Really happy to have you here today on Imaging Informatics Unplugged. And to kick things off, maybe what we can do is we can just kind of set the table a little bit around the work that you're doing in the HIMSS working group around POCUS. And, POCUS, it used to be this niche device that you'd see maybe a clinician have. It's become a lot more commonplace. There's been articles written about this is the new stethoscope, and this is the opportunity of just how clinicians are kind of treating patients and keeping track of them. So I'm curious, as far as the work that you're doing in the HIMSS working group, what are the specific type of challenges that this group is trying to identify and solve as far as enterprise imaging strategies go?
Sure. Thanks for having me. So the challenges that we see in POCUS are that it's still relatively new technology to the healthcare industry. And with that, there are some challenges around just what is it? How does it benefit the health systems? What are the benefits to the patients, the health system, the providers, et cetera? So what we're focusing on are the best practices that we have as a working group of about 85 different members that span across clinicians who are key opinion leaders to people who are on the industry side from a county executive perspective to marketing. And then we have a lot of IT folks who are ultrasound enthusiasts as well, which really help back us up in regards to how this is deployed and how it's going to be managed long-term for the program's ultimate success. So we're focusing a lot on best practices, like I said, but first we decided to strategically begin with governance for point-of-care ultrasound, just in regards to how you form the structure of a POCUS program before you even try to get started. So, what are your goals? What are your governance items when it comes to who needs to be at the table from a clinical perspective, technology, information? We cover all that in the first white paper we had published at the beginning of this year. And that's a really good starting point for anybody to learn as to where they're at in their POCUS journey and where they need to go just to set up the infrastructure before they even consider deploying a full POCUS workflow solution or have any of the attempts of deploying POCUS at scale without having that infrastructure in place.
So it's interesting because I think we work in this bubble where we get often excited about the technology and that almost gets pushed ahead of the governance in many cases. And so as far as the experience that you've seen when you encounter sites that want to adopt point of care ultrasound and want to implement this in their organization, is that typically the area that you see as kind of the Achilles heel of the organization? They lack the governance to be able to move forward?
Yeah, I think it's people like new toys, people like new technology. People may have a preference on vendor or a specific product. and that's departmental. What we try to focus on is creating a POCUS program where you kind of crawl, walk, run, where you're not trying to boil the ocean, but you're also trying to not have a whole bunch of different solutions that are in each different department or location of a health system, really standardizing on what the solution is for the workflow solution. We call that a POCUS manager that integrates into the EHR, so you can pull up patient demographics and any other relevant information for the metadata for those exams, as well as integrate into the archiving imaging system such as the PACS or VNA. So what we're trying to do is tackle it from a holistic perspective, where you're not just looking at what does emergency medicine or ICU need in regards to POCUS, but really what does the institution need as a whole in order to make this thing really live and breathe and have an ongoing success.
It's always interesting when you bring stakeholders that represent different areas of the hospital together, and they're always very often looking at things from their specific perspective. Have you, in the paper, maybe you can highlight what were some of the recommendations that you're, I guess, leading towards when to achieve cohesive collaboration across the departments?
Yeah, sure. So I think one thing to identify first is that not every department has the same needs when it comes to the clinical workflows. There are departments or specialties for that matter, that make sense to stick to an order-based workflow. So they have scheduled patients come in, they know who's coming in, they know what they're going to be scanning them for. Therefore, it is very structured. Where encounter-based imaging is a huge benefit to any departments such as emergency medicine, where they have no idea who's coming through the door, what they're going to need to scan. They don't have time to place an order before they do a POCUS exam. So we see that encounter-based imaging workflow is really beneficial to really any department, where we can expedite the clinician's workflows and eliminate the number of clicks where the exam is performed, the images are acquired, the interpretation is done, a worksheet is completed and signed off on, and then the order is created retroactively on the back end as if it was already placed before the scan. But that ultimately allows for more adoption of POCUS and a lot more just people doing the right workflows in the first place, so that they're getting the information they need in order to have the patient's data, the images, and all that put together, so that they have a full cycle of making sure that the exam is done in the right way. They're able to bill and receive reimbursement for that amount of work.
So the encounter-based imaging workflow IG profile, or EBIW, so you've referenced that, and the kind of the original EBIW has been around for a few years. I remember I was fortunate enough to be in Oakbrook while they were going through the technical specifications for that. Could you elaborate on kind of where does this differentiate now that we're seeing this EBIW with extensions that are calling out some specific areas around mobile devices and POCUS specifically?
Sure. Yeah, it is focused somewhat on mobile devices, but it is also just on point of care in general. EBIW, the profile there is specific to that type of workflow, obviously. We're trying to set up this profile to enhance the EBIW profile so that we have an industry standard on how the patient demographics are represented, and that the modalities themselves represent the data that's necessary in order for these types of exams to be done efficiently. We see a lot of systems out there, meaning ultrasound hardware, that's still set up for a radiology or cardiology workflow. We're trying to move this to the next step to say that if you're going to have a POCUS solution or POCUS devices, that they should follow this new profile in order for encounter-based imaging workflow to be possible. Now, I've been in ultrasound since 2016, and it's the same story over and over, that we can do this, but we're kind of hacking these systems in order to do what we need in order for it to support an encounter-based imaging workflow. Now we're trying to say this is the standard you follow if you want to be a vendor who plays in this space, or if you want to adopt EBIW within a healthcare institution, here's kind of the rules to follow as well.
Interesting. Yeah, maybe I'll take a step back to what you had mentioned earlier with the working group. You mentioned there were about 85 participants in this working group. And I'm curious, I imagine you said that there were clinicians, vendors, a lot of
Mhm.
different folks. So you're going to have a lot of different input about the capabilities. So you're not creating something in an ivory tower that's not possible. You're looking at things in a realistic way that's going to actually be operational. Um, Maybe my first comment is I'm very impressed with the 85. I've been a part of some of these HIMSS working groups, and I've seen it start out close to that number, but by the time,
Mhm.
you've been around for 2 years and the participation starts waning.
Mm.
I'm What do you attribute? Is it because the interest for point of care ultrasound is so strong that, or what would you attribute to the success of the participation, the engagement in this group?
I think it's a few things. One, yes, POCUS is kind of a hot topic right now, and a lot of the clinicians really want to see this be led in the right direction, so that not just one vendor or one group is saying that this is the standard. We're all coming together, kind of across the different committees, across the different health systems, across the different vendors, to make sure that everybody's in agreement as to how this is going to work. Now, having 85 people in a work group is somewhat daunting sometimes, for sure. Not everybody shows up to every session. We have monthly sessions where we're checking in, giving updates to the work group as to where we're at in our progress, allowing the section leads to ask questions to um, my clinical co-chair and I as to which direction they should go in, what they need to focus on, and then they ask the broader group whether or not they can help contribute in any way if they're stuck on anything. So Irene and I, Dr. Irene Ma and I, we kind of lead the direction of the work group to make sure that we're not going down any rabbit holes and that we are focused on kind of what the table of contents was meant to be. Now, having such enthusiasts on the clinical side has really allowed a lot more interest to be in this space as well. So I'll just say a lot of vendors want to be close to these KOLs. And one way to do that is to participate in these types of writings and really be in these working sessions with them, and do somewhat of just a brain dump. There are so many different sides of this that people see, because the vendors see it from one side. Well, the health system see it from another. One provider who's in a specialty will see it different from another provider in a different specialty. So coming together, bringing these people into one working group has really been amazing to see them come together and really adhere to kind of the same thought process now. It's really interesting and really cool.
It is, yeah. The collaboration is impressive, and I maybe it's hard for a week to go by for us to not hear about some cyber attack or security issue or data breach.
Yeah.
Often with POCUS, you're not going to be necessarily sending to the PACS. That would probably not be an ideal situation. You're going to maybe send to a VNA that possibly is not going to be on site. It's going to be in the cloud. I- Talk us through a little bit about the considerations that come into play when it comes to making sure we're dealing with things in a secure way.
Um, so we do have the technology section covered in our first white paper of governance, just to make sure that we're hitting on the fact that these solutions need to be vetted. Of course, make sure that the vendor's solution for POCUS Manager has been through SOC 2 Type 2 certification. They are, of course, HIPAA compliant. They are ready to go in all kind of aspects of security when it comes to the health systems. In our pre-deployment white paper that will be coming out later, we hit on that pretty hard in regards to, is an on-prem solution better than an in the cloud solution, and what are the trade-offs? How fast do you need things to work? What are your security requirements? What are your security limitations? Again, are you allowed to get into business with another vendor through a BAA and have those agreements in place in case there's any breach of information? So we cover a lot of that in these first two papers. We don't quite go down to the level of what a security review consists of, but we talk through the different steps at a high level for, RFPs that need to go out to go out and get information about these different solutions, what it's going to take to go through the contracting side of things from the legal perspective, and really what does it take to get the buy-in from someone like your CIO in order to say that this is a well-vetted product and that we're able to move forward with it.
And
great, great answer, great tips. And so, as we think about like implementation strategies and the best practices around doing this, one of the things about IHE is it's non-prescriptive. You mentioned POCUS manager, or you could have an encounter manager and think, but IHE doesn't define what that has to be necessarily. And so, as far as either what you're seeing commonly or best practices, as far as what the group is recommending, do you tend to see more of a cookie cutter approach that's being taken, or does the flavor of what that POCUS manager does it change very often depending on the implementation?
Well, since this is focused on best practices, we like to propose that the systems would go towards a solution that is catered specifically for POCUS and encounter-based imaging workflow. Now, there are ways to do this without a POCUS manager and to have your EHR, your VNA do something that mimics what a POCUS manager does. Ultimately, it's going to come down to, can those other systems that are not a POCUS manager support things like attestation for any trainer to credentialed user workflows? Is there a QA mechanism? How are you giving feedback to the users, whether they are learners or they are already privileged or credentialed? What is the mechanism for billing? And are you able to retroactively create an order on the back end after a study has been completed and signed off on? So there are some intricacies there that just don't come naturally to what's already in a health system without a POCUS manager. And again, they can be done. They have been done. I've seen them at other places, but there are gaps. So our suggestion is that you go with a solution that is built specifically for point of care ultrasound and supporting encounter-based imaging workflow where it's necessary.
And as far as often what I find is that the driving force for why organizations, at least here in Canada, there sometimes people want to be able to store these for the purpose of at least billing. You have to prove that you've stored this for the billing. Maybe you could talk through that, and then also beyond just the images, is that when it comes to billing, and this could vary depending on the region and the area that you're in. Are there other artifacts like the there's no necessarily a final report all the time. So what actually are we required in most cases to capture and store, to fulfill the need for billing and so on?
Yeah, so it's going to be kind of your common factors here of who's the provider performing the exam, who the patient is, where the images acquired and where are they stored, and then any documentation as to why you did the exam and what you're supposed to do with that data now that you've acquired it. So, if there are any billing codes associated to that, again, kind of a regional thing, but if it's CPT codes for the US, then you got to have those into the documentation so when you submit the result or the billing code, that those line up correctly with what's going to be used for reimbursement. But anything that has to do with documentation, what are the images that were acquired? What's the interpretation of the images? And then, whether or not there's billing codes in those common worksheets, if you will.
So let's say we've got an organization. They're listening to this. They're getting excited. They want to be able to participate and do something like this. What would be your suggestion for them to get started? And I'm going to paint a picture where if things are not working in a Pollyanna fashion, maybe the departments are not getting along. So governance is going to be a big challenge. But we have like the emergency medicine that really wants to be able to fulfill something. Now, what would be your recommendation in a case like that?
Well, that's where we kind of go back to governance. Who's at the table, or who needs to be at the table? You need representation from your IT folks. You need biomed, clinical engineering, of course, clinical folks. Financial representation as well. You need folks to understand what the ROI could be, or actually what the quality benefits are to the institution for introducing a POCUS program. Start there, figure out who you need to have there to represent the appropriate areas of the institution, and then consider, where are you currently at with your POCUS program? Is there, a POCUS deployed in all areas? Is POCUS being utilized correctly? Do you have enough devices? Are you not utilizing specific devices that are hanging out in the corner of a department that can be used elsewhere? Like really do a full assessment of your POCUS inventory. Work with Biomed in understanding if there are devices that are going to be out of warranty soon, if they need to be upgraded. Are they network compatible, as in can they even connect to a workflow solution if you had one? And where are you able to say that you're successfully doing POCUS from a workflow perspective successfully? And how can you use that to your advantage to move that into the next department? So anytime that a health institution is looking to start a POCUS program, we recommend that you kind of crawl, walk, run. And with that, where's the department that has the most interest in doing this or has the most impact utilizing POCUS? So once you've landed that, call it pilot, use that to your advantage to roll it out at other areas of care, whether it's another location with the same specialty or you're in the same location and you're just going to go through different departments, utilizing the same solution, the same workflows, and really having your clinical champions driving this, as well as any technical champions you need in order to help support it. Without those two things, you're not going to have a lot of success in moving this forward. So you got to have your clinical and your technical champions really driving the success of this.
Terrific. We're getting close. I don't, try to keep these conversations a little succinct here. I might throw maybe one more question at you. And I'm curious if the group has AI come up, and often you'll hear, the opportunity of having your own POCUS device at home. I don't know how to scan it or use it, but maybe AI could help with procedure guidance and so on. Has any kind of AI or ML opportunities come up in the working group discussions?
Yes, AI will be something that we focus on soon, hopefully before the end of this year. But we have a mountain of work to get through still for the remainder of 2025, honestly, with all the content that has been put together so far, and then the work that's going to be put together for our third topic of focus, which will be on deployment itself. So the first paper that was published this year was on governance. This next white paper that we're going to submit for publication here shortly will be on pre-deployment. The third one will be on deployment itself. After deployment, we can look at the fun things of AI and other things that are going to help people understand how to do imaging without necessarily being a clinician themselves or being a radiologist in order to interpret the data. So AI has come up in our work group sessions quite a bit. It is something I'm interested in leaning in on to see what kind of content people put together, because I know in the industry side, there's a lot of development going on with that. And it's really, really awesome to see things from image recognition to automated documentation and then QA. There are a lot of things that are really going to expedite the workflows and the feedback for the providers. So we're looking forward to diving into that, but it's not something we're currently focused on, but we will be.
Exciting. The future is bright. Maybe if you want, you can close out. I will make sure to include the link to the original governance, and depending on the timing of when this goes out, maybe we'll have a reference to the second paper by that point in time as well. If there's anything else that you'd like to maybe just a final pitch or a plug of anything related to the working group actions here, I'll leave you with just final thoughts about POCUS and the future.
Yeah, sure. So we will be presenting at SIIM 25 in Portland, Oregon in May, late May. With that, we hope we have quite a bit of participants there who just want to listen to what we've been up to, what we're doing, what's next. But I can't thank my clinical co-chair, Irene Ma, enough for her participation in helping us get the first white paper published over the holidays. And then just a thanks to all the participants in the work group as well. I couldn't do this without them and all their great work. We structured the work group in a way to where, as I mentioned before, Irene and I kind of give the direction, but what we're doing is assigning specific individuals to each section to lead those bodies of work. And then they have their co-authors who work with them on these working sessions, and they are putting together their drafts for Irene and I to review. And once they say they have a final draft, Irene and I will go through and make sure that they're following the narrative, and then we'll put those sections into the appropriate order. And then, of course, make sure all the references are in there, put it together, compile it, and submit it for publication. So that's what we're in the midst of right now for pre-deployment. But that's been a successful model that we found works really well for leading a large work group of this size. So yeah, again, can't thank Irene and the group enough for their participation.
Well, thank you very much. I'm looking forward to seeing you and the rest of the group at in Portland in May. And yeah, it's going to be a good time. And we'll see you there. Thank you very much, Allan.
Be the dream machine. .com, HO7, IHE, and Snap. We're building the future, never looking back.